good afternoon, good evening. We have people joining us from all around the world, so thank you. This is one of the first breakout sessions of this year's GSG Summit, and really looking forward to it. It's going to be a great one. It's about health ventures, and it's about the world ahead of us. The pandemic has exacerbated the challenges and limits of underfunded healthcare systems. The most vulnerable have been disproportionately hit by the health consequences of the crisis. However, the pandemic has also resulted in numerous health startups redirecting their products and services to help public health systems, and a number of innovative financing mechanisms being created. We're going to discuss all of this today. Hopefully it will be a very interactive session. The session is going to be recorded, so do please make sure your questions are good and hard ones to keep our excellent panel on their toes. I will introduce them shortly. Just very quickly, my name is Kieron Boyle. I helped establish the Global Steering Group from the UK Cabinet Office, but I'm here in my capacity as the Chief Executive of Guy's and St Thomas's Charity. We're one of the world's largest urban health foundations. Delighted to be joined by an excellent panel. We have two of the panel with us at the moment. So we have Helge Weiner-Trapness, and I'll ask Helge to introduce himself shortly. And then we also have Bannirchelvam as well, joining us from Singapore. Hopefully Dr. Jemilah Mahmood will be joining us as soon as the technology allows. So just to get ourselves going, I'm going to ask a few questions and then we'll have a conversation and take it from there. Do please use the chat function or the Q&A function to ask any questions at any point during the session. So perhaps just to get us going, it would be helpful, I think, for all of the participants just to hear a little bit more about what you both do and what your connection to health ventures is. So Helge, perhaps you could just say a little bit about what you do.
Sure. What I do in my day job is as the founding partner of Quintus Partners, which is a small investment banking boutique with offices in New York, California, and Hong Kong. I work, as I have for the last 30 plus years, as an investment banker, but more importantly for these purposes, and actually something I enjoy more than anything, is I'm also a director of IFIM, the International Financing Facility for Immunization. And obviously, IFIM, as you may know, is basically the finance arm for Gavi, the Global Vaccine Alliance. And we get pledges from governments around the world, and we take those pledges and basically issue vaccine bonds, which front loads the money that governments are giving us under legally binding pledges that last for 10 to 20 plus years. And we're able to upfront all of that money so that it can be put to use for vaccinations around the world in 50 plus poorest countries in the world. And that's what IFIM does, and that's why I'm here today.
Great, thank you, Helge. And Sean, likewise.
Thank you, Kieron. So my name is Bannirchelvam. I'm a managing partner of Global Impact Hub. We're an impact investment advisory firm with offices in London, Singapore, and Australia, with a simple mission: to mobilize capital to serve people on the planet. The key platform we work on that's relevant for today's discussion is the Global Health Impact Partnership, which was a platform we launched last year's GSG Summit as a platform to deploy $1 billion over the next 5 years into a series of outcomes-based financing instruments in healthcare, together with the team out of Stanford Medical School. And the whole focus is in using artificial intelligence and key tools in primary prevention to target a cluster of diseases, looking at cardiometabolic disease, maternal and child health, and tuberculosis. What's been particularly interesting in this work, and we were working on this for about 2 years prior to COVID-19, has been the cross-country solutions that we see, where sometimes the issues we're facing in Tower Hamlets in East London are not too dissimilar to some of the health challenges we see in parts of Indonesia, in Malang and East Java, or even parts of India. And COVID-19 has really exacerbated these inequalities. We've seen, for example, where someone with no comorbidities, from the data WHO has shared with us, has a 1.4% rate of mortality versus about 13.2% with cardiovascular disease. And this is really something which we think outcomes-based financing play a key role in tackling globally. So thank you, Kieron.
Yeah, wonderful, wonderful. Well, we're going to have a great discussion. I know that. I know that already. It would be wonderful also through our discussion if any of the attendees would like to use the Q&A to share any thoughts or reflections with us. I think we have numbers enough that we'll be able to, with France's help, call on people to speak in person as well if they'd like to make their point in person. But I'd like to pick up on that last point that you made, Sean. This session is about the challenges of DFIs in tackling the COVID-19 crisis, which is a health crisis, it's an economic crisis at the same time. Because of that, COVID has accelerated health inequalities that were there all along. What do you think we should be learning from this for the future of healthcare? Sean, I'll be interested in your thoughts, and then perhaps Helge, yours as well.
Sure. I think the one thing we've seen with this, I guess, magnification of the health inequalities we've seen is then thinking about what are, on the flip side of that, solutions that help tackle that. And the fundamental challenge we've seen is often with a lack of underinvestment in primary prevention. And we see this not just in LMICs, but even in high-income countries like Australia and the United Kingdom. There's a real importance to try and tackle this gap in primary prevention effectively. The other part I'd add to that, though, is also the opportunity before us, where COVID-19 is a real chance to build back better from this, where with the resources we're now putting into the recovery to actually look to strengthen primary care, especially with the right digital-enabled tools to make that leapfrog jump forward with a lot of what the promise of digital health now provides us. So an example that I can share here is, so the team we work with out of Stanford Medical School, they've now got our data on 200 million patients across 10 years from 30 countries. And what they're able to do that in real time is identify what key care gaps are, what is working, what isn't working in the field, to optimize care in real time for what's happening on the ground. Now, coupled with the digital tools we're able to put in the hands of, in India, what are called ASHA workers, in Indonesia, Kader workers, who are basically community care workers who are trained typically within 1 to 2 weeks, sometimes up to a month, and then equipped with the right PPE to go out and do the screening, can be an incredibly powerful tool as a way of actually enabling health access. Because the other part I'd add, which confounds that, is then also the medical practitioner ratio, where if you look in India, the ratio is under 1 per 100,000 versus typically 3+ in high-income countries. But once again, we are never going to tackle that when you look at sheer population demographics of, population growth rates versus medical college graduation rates. So I think taking the right thoughtful approach can be quite valuable in tackling this. Then the final piece I'll add is when we look at on the investor side, some of the pension funds, banks, insurance companies we engage with on this, for them there's been a strategic focus at seeing how they can actually increase allocation to the sector, and the right risk-adjusted instruments where, coupled with the thoughtful use of DFI capital, can have a significant catalytic effect in this to ultimately multiply the impact of increasingly scarce DFI dollars.
Really interesting. So points there both on the sources of investment capital and where they're coming from, but your points also around the innovation that is needed and how we think about healthcare as well. Helge, from your perspective, what should we take from the COVID-19 crisis as we think about healthcare in the future?
Now, I think of it from a little bit more macro perspective. I think a couple of things that are obvious, but are very, very important that we learn from this. One, of course, is preparedness. This isn't the first time isn't the first time we've been hit by a pandemic, although it's been a long time since it was this severe, but it's going to happen again. And I think this is a real wake-up call to the world, both the wealthy world and the less wealthy world, that we need to be very, very prepared for this. And this is not something to take lightly. The second issue is that these are worldwide problems, and they require cooperation. To protect us all from this, we actually need to work together. And this is not a selfish game. This is a game where the rich can't just go up in the corner and decide we're going to fix this and they'll be done with it, and the rest of the world doesn't matter. This is a one where if we don't deal with this on a global basis, and I think this will be the case for future health scares as well, and healthcare in general, we're not going to be as effective with it. And again, the cooperation therefore that's needed scientifically, politically, sharing of best practices is absolutely important. And I think at IFHIM and at Gavi, we're seeing that with the COVID facility and the COVID accelerator in terms of this specific pandemic and how we're dealing with it. And it's that kind of cooperation on a worldwide basis that's absolutely paramount going forward if we're going to deal with these issues as we move along.
From our work in London, I think one of the things that we've really noticed is the future of healthcare will need to be wider than what we classically think of as healthcare. Vital though the medical and the biomedical side of things is, I think what we've seen in the passes of health inequalities is we need to be thinking about air quality and income levels and all the effect that these wider determinants have on people's health. The effects of COVID has not been felt equally, and so we need to address those. Which brings me to another question. I'd be interested in both our panelists' perspectives, but perhaps also from the attendees as well. On the one hand, healthcare does not lack for investment. So I'd be interested in your perspectives on what specific role impact capital should play. Helge.
Well, you're right. I mean, healthcare does not lack investment capital. The problem is that it is oftentimes very narrowly focused in generating direct financial returns. The problem we're dealing with is basically we have massive positive externalities here from an economics perspective, where some of the huge investments that get made that have enormous beneficial results to countries and the world in general aren't being made because they don't necessarily generate direct financial returns that financial investors are looking for. And I do think, for instance, vaccines is a perfect example of that. IFIM and Gavi vaccinates 70 million children around the world in the 50 poorest countries in the world every year. And that is an investment that if it wasn't for the Gavi's huge efforts in terms of every 5 years raising the money to do this, wouldn't happen on its own. And if you think about the actual economic return that provides the world, it's enormous. Johns Hopkins has a terrific study that shows that for every dollar that's gone into vaccinations of children in the poorest countries in the world, if you look at the economic impact of that, it has returned $54 for every single dollar invested. From a financial return perspective, that is absolutely astonishing. If you ask any investor in the world if they could get that return in dollar terms, would they do it? They jump on it every day and twice on Sunday. But that would not be done if it wasn't for organizations like Gavi and other global health organizations who do that kind of work.
And Sean, from your perspective?
So one thing we've seen, and I think this is particularly pronounced in LMICs, particularly the ones we see in Asia, where if I was to do a pie chart, and I don't know this data in front of you, but my guess would be a heavy structure through which private capital has played a role in healthcare has predominantly been through private equity, and to a lesser extent through venture capital and to early stage, say, med tech, rarely biologics in LMICs, more typically med tech solutions in the region. Where I think that leaves gaps is, building on what Helge said, where sometimes systemically there are these externalities created in that are actually these systemic value-based care programs, right? Where we think about whether it's tackling something like cardiometabolic disease, maternal and child health in the region, what we've seen firsthand is there might be key to a chain of, say, maternal hospitals, which focus on deliveries in private hospitals. There may be investments on the medtech, but the actual economic incentives to bind that together is where I think pay for performance can play a significant role within that, in aligning those incentives, and where I think the need arises. The other trend, I think, which supports us from our work that we've seen in the region, is actually the increasing expansion and policy level of these large government health coverage schemes. So, for example, in Indonesia, they have a program called BPJS, which at its full implementation will provide healthcare for over 200 million people in Indonesia. I think they're currently up to over 100 million. Similarly, in India, there's a scheme called Ayushman Bharat that's being rolled out, which built on, to some degree, existing state-level health insurance programs, But this very much builds on that. And that then creates economic incentives to then be able to engage in the type of pay performance work that the UK government did such a great job pioneering here. So I think this alignment of incentives, which previously often led to cracks, where if you look at private equity into healthcare in a number of these regions, typically catered to the middle and high income consumer, now creates economic incentive and the ability to actually structure an investable instrument targeting a much broader range of individuals we can serve.
So central in both of your comments there was the vital role of governments. Are you optimistic or pessimistic around the capacity of governments to engage in these sorts of recognition of the positive externalities, recognition of the role that outcomes-based financing can play on these sorts of healthcare issues?
Shan, go ahead.
So I would couch my answer over two time horizons. So I'll talk firstly about the short term and then the mid to long term. In the short term, I would say, Kieron, I'm slightly pessimistic, not because of lack of will, but just because of the sheer challenge of dealing with the incredibly abnormal situation we finally find ourselves in, right? Where a lot of the governments we've been engaging with were just putting out fires left, right, center for the last 3 months. And now that they've kind of got their heads up above water and have straight under control, there's very much focus to get back on track with a lot of what they were doing initially, right? And that's to varying degrees depending on the status of COVID-19 in these countries in, I would classify, emerging Asia, as well as even, I'd argue, Australia and the United Kingdom, where we've also been engaging. Over the mid and long-term horizon, why I'm quite optimistic is governments have truly seen the value of why this is important. So I'll give you an example. In Indonesia, we're engaging there with the Office of President Jokowi, and one of the mandates they've given is actually to use this as an opportunity to actually reform healthcare in Indonesia. And we hear very similar comments in engagement with governments in India and even Australia to that extent. So that's why I'd say over that mid to long-term horizon, I think I'm optimistic. Short term, a bit more pessimistic, just because of the sheer burden of what they're currently tackling. Helge?
Yeah. Okay.
Yeah, I'm by nature optimistic, so I think both short-term and medium and long-term. I do think that governments will continue to engage proactively and in a very positive way in solving these regional and global issues around healthcare. It's easy to be a little jaded as one look at kind of the political debate around the world, where you kind of see rise of greater nationalism carrying first, kind of a selfishness, if you want, politically around the world. I'm sitting in the US from that perspective looks like an example of that. But I will counter that by saying, if I look at Gavi's recent fundraising, which cleared up or which finished up here this past summer, the global support, and again, for many of the countries where if you look politically, it may look like it's becoming more self-interested, many of those countries around the world continue to support very, very strongly Gavi, which I think is again, very encouraging, very positive, and it keeps me very optimistic about both today and the future. I think people are realizing that in the healthcare area, we have to work together and deal with these problems and solve them on a global basis. And not just this pandemic, but you talked about quality of air, quality of water, etc. around the world. These are issues that we can't, any one nation can't solve it alone, and we've got to work together with it. And I think there's positive signs, and I think it's definitely worth, and we can be optimistic that it's being, and it's going to continue to be very focused on by governments around the world. So while they may look a little darker in the near-term horizon, I think overall we should all be very optimistic about it.
I'm very fond of saying that health is a collective outcome rather than an individual one, and I share your sense of optimism. I like the difference in time frame that you both used there. We have a question to us. Francis, might we be able to hand the microphone to Fatima? Fatima, hello.
Hi, good afternoon. Thank you so much for your contributions. It's been very interesting listening to you. I just would like to ask, we're doing I work in Nigeria and we're mapping out investment opportunities across all, across the whole country, across different sectors. So we have healthcare, education, renewable energy, and we're trying to identify investment opportunities that generate impact, but are also financially, that generate financial returns as well, and also have ability to scale. And for healthcare, it's been a little challenging identifying business models that fit all of this criteria. There are huge opportunities within secondary and tertiary healthcare provision, huge opportunities for investments, but we find that in terms of primary healthcare, we haven't been able to identify business models that cater to the people, but also generate financial returns. I think it's mostly because that is a heavily regulated area, but it's very government-led. So I'm just wondering if you have any ideas on what opportunities exist, or if at all there are opportunities for private investments in primary healthcare.
Yeah, really, thank you, Fatima. A really important question, and I think it touches on a number of critical themes as well. Sean, perhaps I could start with you, either kind of general advice or based on your work. Where have you seen the impact investment opportunities around primary care in particular?
Sure. So I should caveat anything I'm about to say, Fatima, by saying I know very little about the health system in Nigeria and the ecosystem. But if I can sort of abstract from some of what we've seen in the region in the Asia Pacific, one thing we did when we actually started analyzing the health system before taking this path to outcome-based financing was to actually break down the value chain within health, right? From everything upstream, from kind of the work Helge looks at around immunizations and very, very early prevention. Now you through to the, what I'd say, early stream of that, which is then primary prevention through the secondary and tertiary care. And when we broke that down, we realized a number of cost layers to it. And to the degree you're able to kind of decouple and break down which of those elements is actually the key cost driver, if there are ways to adapt and work around it, it can be valuable. So I'll give you an example. In India, where we were working with the state government on a primary care program for a state of about 38 million people. There, what we've actually been able to do when we broke it down in primary care areas, the key cost for them was less the medical staff, but actually more the building and development facilities. And what we also realized, there's a lot of disused government buildings through the city that had grown out through the entire period. So they were owned by the municipal corporation that could actually be repurposed for primary care centers. And the Delhi government has also done a very successful job of this, what I call mohalla clinics, or low-income community clinics. So that ability to just think strategically about what resources are available, how you can leverage those two, that's important. And then I'd say, to take that a step further, what we saw is when we then looked at another key barrier, which is actually medical professionals. And this is, I go to your point on how do you make an investable case, right? I mean, to very broadly simplify, you've got ultimately revenue and costs, and you've got to think which of those levers we can push at. If we're able to then drive down the costs through thinking about new service delivery models, that could potentially be pivotal in primary care. So that's where the whole model of using ASHA and Cadera workers came in, because we realized ultimately we were never going to get enough medical practitioners out. So we had to find ways to leverage with the right technology community health staff. So taking a systems thinking approach and actually thinking laterally about the type of resources you can leverage could be quite helpful in considering that. But once again, that's very general advice based on some of what we've seen here without any understanding of the system in Nigeria. Helge, I don't know if you had anything to add.
Yeah, and thank you for that, Sean. I think that's very thoughtful. I do think if you look at investment and where the greatest return for the economy, for Nigeria in this case, would be, for any country, it would be indeed in strengthening the fundamental, kind of health system that exists, and that usually starts at the broadest basic base, which is primary care. And now, from a private financial return perspective, this is exactly where the positive externalities factor in so greatly. It's much easier to build a case for, let's build a fancy hospital in the biggest city, perform a lot of advanced elective surgeries and make a lot of money doing that. But that can work from a, if you want, a private equity financial return perspective. But for the country as a whole, it is probably better invested in health system strengthening and primary care provision, and the direct financial returns to that are less, less relevant or less ready, while obviously the broader societal economic returns from that are enormous, and it's kind of difficult to pair the two. But this is indeed where governments have a very important role to play, because I don't think that building the primary care systems to the point that is needed in many of these countries is particularly well suited for private capital. And it's primarily, again, for those economic externalities that aren't picked up and aren't paid for, but are enormous benefits to the society as a whole.
Yeah. I would add to that. Also, please, everybody, be thinking if you have other questions for the panel. I would add to that two perspectives from our work in a major global city, but I know the Nigerian context less well. One is actually just to repeat the systems thinking point that we heard. It's interesting to me that you said that you're looking for investments in healthcare and education and a few other areas. I would argue that from a health perspective, investments in education can be one of the greatest healthcare investments that we make. This can be very practical. We use our endowment as which we use for impact investing, to invest in social housing. The reason we invest in social housing in the UK is that we think that will have a much greater impact on health inequalities than many of the healthcare investment opportunities open to us. So that's all kind of systems thinking. What really is the route to the impact that you're seeking? I think I would also pick up on a point that both Helge and Shan had made earlier, just around the importance of data as well. I think and the effective use of data within primary care. It's not always the complicated stuff. A quick story, if I may. An investment opportunity available to us was local primary care. Where we work in London, we have a very large Afro-Caribbean population, have high incidences of diabetes, and spotted around November, December, real flare-ups in people's diabetes self-management. It was very unclear to the system what was going on, why that was. Better data enabled it, general practitioners, to see that what was happening was that a lot of the local Afro-Caribbean population were going to the Caribbean to see friends and family in those months, and their diet was shifting quite significantly in those few months that they were visiting families overseas and then coming back. And so the general practitioners were able to use that data just to set up Zoom calls for when people were in the Caribbean. I need to say that we sometimes can feel kind of very complex stuff, but it's really not necessarily the opportunities are sometimes quite practical. Do we have any other questions from any of our attendees?
Hi, Kieron, it's Francesca. I just wanted to say apologies from Jemilah, who is unable to dial in. We have had some issues with people using the Zoom link directly, so just apologies for that. We do have a question in the Q&A box, so maybe I can read that out. It's from Kate Jarvey. Kate asks, from the perspective of healthcare for those with disability and their families, does any impact investment consider the enormous potential for financial return from the whole health value-based systems and programs for this sector of the global population? And then she says, COVID has hugely increased the health and social challenges for those with disability and their families. So Kate, if you'd like to unmute yourself and kind of talk about that question, feel free, but otherwise over to Kieron.
Kate, would you like to add anything to that?
Yes, is that me
Thank
now?
you.
Can you hear me?
We can hear you, Kate.
You can, yeah.
So yes, I work in the disability sector. I'm a lifelong philanthropist, but I work in the disability sector. Disability is always lumped into healthcare in my experience, which isn't always appropriate for it because a lot of it is social challenges as well as career challenges and so on and so forth. But from the work that we've done and the research we've done here in Ireland, I'm from Ireland, social isolation is the #1 priority. But it's impossible to explain to potential investors the return for their investment in value for value-based whole health programs for those with disability that bring them into the network of life and bring their gifts to our table. The moment, to a huge degree, their gifts are excluded from our mainstream table. How could you look at making an investable case for changing this around for people with disability? Thank you.
Thank you. Very good question from Kate. How do we make an investable case for turning that perspective around for those people living with disability? Sean, do you have any thoughts for Kate?
So, Kate, this is not, once again, a direct one-to-one analogy, but something very powerful that was done, this was about 3 years ago, by an assistant secretary in the Australian Department of Social Services, where she actually roped in an external actuarial team, and they spent a whole period looking at the lifetime costs of disadvantage within childhood and youth, right? And that really laid all the groundwork for our subsequent work in Australia on and after the financing, because I think you make a very important point. Yes, I think there are these much broader societal constraints that frame the issue of disability. We've seen some of this in our work in Australia, where we've worked on the other end of it. We're trying to prevent diabetes and stroke to not then lead to disability downstream. But I think that same opportunity does sit downstream as well, where by then doing that detailed analysis, they were actually able to come up with these quantifiable lifetime costs and look at trajectories that led from that, which had actually built the investment case for the Australian government, shifting part of their policies within that area of youth and childhood disadvantage, right, to lead to better lifetime outcomes for these individuals. So I guess, is that a private sectoral approach? No. But I think that does show the vital role government does play in any of the kind of reform we talk about in what we do. So that's sort of, I guess, one approach I've seen that was actually quite effective in getting that policy cut through. And interestingly, I should add, it actually had cut through across both our Labour and Liberal governments. The fact that it was able to cut through, I think, is quite important because of that rigorous quantitative approach they had that led to that sustained support. Okay. Or Kieron, I don't know if you have anything else you'd like to add.
Helge?
Yeah, Kate, first of all, thank you for your question. And I think it's a very good one and very important one, but also a very, very complicated one to answer. I mean, we know kind of from kind of an economic perspective that both from the person with disability themselves as well as the caregivers, in many ways, the more we can draw both of them back into society to become part of society to a greater extent than they otherwise would be, not being so isolated, is beneficial from so many perspectives, including in certain cases economic perspectives. But I don't have, it's still very difficult for me to kind of quantify and come up with how would you actually begin to try to quantify that to kind of gender a private investment in this. Again, I think sadly it falls on the community and society to help support this and to make kind of a direct financial argument for to get private equity or private capital involved in it directly is a harder one to do, given how hard-nosed they looked at the dollars and cents. there's no doubt in my mind that there's enormous benefits, again, to society, to the individuals involved, both on this person with disability as well as all the caregivers around, that there is enormous benefits to society to help them and to integrate them greater into society and the community. But how to specifically economically quantify that, I am still at a loss about, and I apologize for that, but I'm sure greater minds than mine can find a way to do it.
Yeah, and are working on it in the ways that you described. Kate, I think I would add from my perspective, I think it does ask a really important question though of impact investment, which is whose voice is around the table. When we look at impact investing firms, impact investors, are there sufficient perspectives of those living with disability themselves or in their families or close circles? I think it's an important question that as impact investment seeks to have ever greater and deeper impact. You know, Cliff and Ronnie have been speaking about at the start of this summit. I think we do need to be asking these quite challenging questions of the impact investing community. Kate, thank you for that question. There's we have another question from Lorian. It's a wonderful question, and I think actually might be the last one that we have time for. Somehow 45 minutes has almost flown away from us. Lorian asks a fantastic question. How do we balance off health investment meeting the needs of the vulnerable versus the need for profit and returns on impact investment? Lorian, would you like to add anything to that question?
Well, since you have limited time, I think let's leave it at that. If you don't answer my question, I will put in on you. Thanks.
Yeah, no. What is it? It's I think it gets to the heart really of the question of what are the challenges around healthcare and going forward and tackling the COVID-19 crisis. So, Helge, you spent a career in a way looking at this question. How would you respond?
Well, so let me use IFM as an example, because as I mentioned before, Johns Hopkins is clear, showed through studies that they've done repeatedly how enormously strong the economic return is for every dollar invested in vaccinations of the poorest children in the world. And it is an enormous return. Again, as I mentioned before, every single dollar invested in this returns to broader society $54 in direct economic returns. And what this is not only do these children who get vaccinated grow up to be contributing adults to society, but also they are much less sick when they're young. So as a result, their parents don't have to stay at home to take care of them, can also be contributing to society. And when you add it all up, it's an enormous benefit to economic benefit to society to do so. Now, the problem with private capitalists is that if you were to buy a vaccine for a child, the economic return is attributed to society. It's not coming to you as a private equity investor back. So as a result, some of the most important, highest return opportunities to invest in healthcare around the world is not particularly well suited to private capital. And this is again why I think we need to think about this as a joint venture where in the for-profit world, great, let's bring in as much capital as we can to make sure that we find the right cures for diseases, et cetera, that can be paid for and that can generate a financial economic return. But when it comes to other equally, if not even more important investment opportunities, I do think we're going to have to continue to look to governments to work on a worldwide basis to support it, as well as to philanthropies to support it. I mean, if we think about the Bill and Melinda Gates Foundations and many, many others, Wellcome Foundation, etc., who've done enormous good around the world by taking the private wealth that they've generated and putting it back into the broader society. And I think that kind of dual economic purpose, if you want, both of private equity doing what they should do and do it well as philanthropies and governments doing what they need to do, particularly to close this gap, as we've talked about, around externalities, where private capital isn't well suited to do that, but governments and philanthropies can do that and are doing that. And I need to continue with that kind of dual approach to dealing with these global issues.
Thank you, Helge. Sean?
So very quickly, Lorianne, I would echo a lot of Helge's points, and it's got to be the right form of capital. I want to emphasize that private capital on its own is not a panacea, but that thoughtful and right use of it can create the fiscal space, and that expanded fiscal space can then provide government's capacity to fund the uninvestable components while shifting the investable aspects. And I'll give you one example from Australia. I think one really successful example is the way we funded infrastructure in a number of the states, whereby spinning off assets, the government's been able to unlock the capital, over 25 billion in New South Wales alone, to then fund new greenfield infrastructure, which was often uninvestable just because of the contractual risks involved. So I think the thoughtful use and blending of different types of capital can go a long way in potentially helping bridge this gap. But private capital is not a panacea. It is hopefully just part of that solution.
If I, Kieron, could just add one other point, there are other mechanisms where we can marry the two, because they're not two separate buckets. And actually, IFFIM serves that purpose, if you think about it, because yes, the capital that we raise gets used by Gavi, and it's being put to use for vaccinations in the poor world, for young children there. But at the same time, what we do is we package the public capital we're getting from foundations as well as from governments around the world to issue vaccine bonds. I mean, we take them to the capital markets and tap into private fixed income capital to actually use that capital to accelerate what Gavi then does in health system strengthenings and delivering vaccines around the world. So there are mechanisms that I think we should think about and explore and do more of, if you want. We do it very much on the debt side with IFFIM, with our vaccine bonds, but there should be other ways and other means to do that, both with private equity capital as well as with private debt capital.
Wonderful. Well, I think that's a wonderful note to finish this session on. Thank you, everybody, for all the questions. Particular thanks to Helge and Sean for such a thoughtful exposition. It's helpful to know that we should have such reasons for optimism in tackling the healthcare crisis. Thank you.